I'm Rod Rourke, and I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the February 2017 edition of the PRS Journal Club podcast. My name is Shuja Shafqat, PRS resident ambassador from Lehigh Valley, and I'm joined by my co-ambassadors Jordan Frey from NYU and Chad Purnell from Northwestern. Today we have the honor of being joined by Dr. Greg Dumanian, Chief of Plastic Surgery at Northwestern University. Thank you so much, Dr. Dumanian, for joining us for this PRS Journal Club podcast.
My pleasure.
So the article we'll be discussing next is entitled Wound Morbidity in Minimally Invasive Anterior Component Separation Compared to Transversus Abdominis Release by Drs. Parent and Horn, Lauren Jacobson, and Drs. Peterson, Hinojosa, Yates, Wright, and Louie from University of Washington in Seattle. Just everyone remember that these articles can be read for free on prsjournal.com, including an archive of all the past Journal Club articles and their pairings. So the authors, just to start out in their introduction, talk about anterior component separation being a well-established technique for the advancement of abdominal muscle and fascia to the midline. But as we know, that creation of large skin flaps can lead to compromise of the soft tissue, and thereby people have developed endoscopic or minimally invasive approaches to reduce wound morbidity. In addition, transversus abdominis release is a newer technique that has also been used for myofascial advancement with potentially less wound morbidity as you avoid making large skin flaps. And the authors do note one study by Kripata et al. In American Journal of Surgery in 2012 that showed decreased wound complications and hernia recurrence for the transversus abdominis release, but that was only compared to open anterior component separation. So the author's hypothesis was that minimally invasive anterior component separation described by Dr. Butler would have a similar wound outcomes compared to transversus abdominis release. So they basically did a retrospective study on patients from 2010 to 2016 undergoing ventral hernia repair with anterior component separation or transversus abdominis release. Patients were excluded if they only went a unilateral or a partial anterior component separation or a different type of release. The decision to perform either was basically based on the surgeon's preference or ability, and permanent or biologic mesh was either used in a retrorectus or underlay position. Their primary outcomes were time of surgery, as well as multiple different wound complications, including hematoma, seroma, skin necrosis, wound infection, mesh infection, hernia recurrence, and need for reoperation. They also did look at some secondary outcomes, including pneumonia, UTI, bacteremia, DVT, PE, cardiac arrest, and mortality. They followed up all their patients at 1 and 6 months with the exception of 4 patients, and they did have some additional follow-up was counted only if there was a description of the surgical site. So in total, they had 142 patients, 75 anterior component separation, and 67 transversus abdominis release and cohort matched. Of note, the anterior component separation patients had a higher percentage of immunosuppressed patients as well as higher ASA class. Their median hernia size for anterior component separation was 400 square centimeters versus TAR, which was 340. Majority of the patients had recurrent hernias, around 62%, and most were ventral hernia working group 2 or 3. Of note, if you look at Table 1, the anterior component separation patients also had a relatively higher BMI at 34.1 versus 30.6, and a higher number of patients with diabetes. They also did notably have more biologic mesh inserted as opposed to more synthetic mesh in transversus abdominis release. And also one patient had a paniculectomy at the time of their hernia repair. Overall, their median follow-up time was around 8.8 months, and they found no difference in wound complications, including hematoma, seroma, skin necrosis, wound and mesh infection, recurrence, which they noted was 12% in the anterior component separation and 6% in the TAR. Reoperation was for multiple reasons, including recurrence, infection, and small bowel obstruction. That was also similar between groups at 19% for anterior component separation and 12% for transversus abdominis release. It is worth noting that in Table 2, they do note that overall wound morbidity in all these different categories was around 43% for anterior component separation and 39% for transversus abdominis release, which are not insignificant numbers. They also note a similar rate of infection between biologic and synthetic mesh, no difference in surgical time, and no difference in any secondary outcome measurements. So in their discussion, they go over some of the results of that study they mentioned in the introduction, looking at higher recurrence in anterior component separation, higher wound complications, but again, that's in anterior component separation patients. They did note that in that study, more paniculectomies were performed in the anterior component separation patients, which could lead to a bias in the TAR group with results to wound morbidity. In this author study, they found that they had longer operative times by 1 to 2 hours, and basically they had non-significant trends in the transversus abdominis release towards fewer reoperations for complications and fewer recurrences. Prior studies have shown that complications in TAR tended to be less severe and less frequently needed reoperation. However, they do note that this would have to be studied further. Limitations they noted were basically small sample sizes, residual confounding or bias, including selection bias, as there wasn't really any randomization of patients to either procedure and also a relatively short follow-up. So overall, I thought it was an interesting study in looking at minimally invasive component separation versus the traditional open anterior component separation and the transversus abdominis release. I do know that there are multiple different ways in terms of doing minimally invasive component separation, including multiple studies by you, Dr. Dumanian, so I'd be interested in hearing your thoughts about this paper.
Well, the first report about a minimally invasive means to do an anterior component was by Maas, M-A-A-S, from Europe. That was approximately 1999 in JACS. That was in 4 patients, and in 2002, I compared about 45 patients who had a perforator sparing anterior components versus traditional open, all done by me, the single surgeon. And we dropped wound complications from the way we were defining them from the 20% range to the 4% range. Butler, using tunnels, and that's essentially the way I had described it back in 2002, also showed decreased wound complications from anterior components to minimally invasive, and that was in 2012. The TAR release was done and brought into essentially surgical consciousness by Nowitzki and Rosen as a way to just not deal with the skin. And they do wide undermining of the posterior fascia, releasing the semilunar lines to mobilize the posterior fascia, the posterior rectus fascia, to bring that and to have essentially a soft tissue sandwich around gigantic pieces of mesh, sometimes 1,000 to 1,200 centimeters in square diameter in surface area. So the whole issue of this paper, looking at soft tissue complications, unfortunately avoids the central issue of a hernia closure, which is how do you put the tissues together and how do you distribute forces to provide a meaningful closure of the abdominal wall. So in neither the TAR releases discussed nor the anterior components released is it discussed how they put in the mesh. Is it held in by friction? Is it held in by sutures? Is it a small piece of mesh which could avoid wrinkles on its edges? Or as they do in a TAR release, is it a gigantic piece of mesh held in essentially by friction? So I think that until the surgical technique is completely solidified, it is difficult to make meaningful comparisons of groups. I think that this shows that in reasonable academic centers, you're going to have comparable wound complication rates, but which one is actually better will require the optimization of the surgical technique first and then a comparison. In this group, as you discussed very accurately, BMIs were bigger in the anterior components. They used more biologics in the anterior components, and biologics have been shown in multiple studies to have more wound complications than synthetics. And then this over 6-hour operative time, they themselves admit that that's kind of long. At Northwestern, we're doing anterior component separations for our tertiary referral center in 2.5 to 3 hours. And Mike Rosen and Nowitzki both described doing a TAR release in the 3 to 4 hour range. So 6.5 hours is, as they admit, outside the established literature for how long these procedures should take. So, and only 20% of them had bowel work done. So it's not because all of them had low anterior resections and bowel takedowns. Only 20% of them had bowel work. So I'm at a loss of why these procedures were taking so long. And again, you're asking for perhaps comparisons between non-optimized surgical techniques. In terms of paniculectomy, I'm maybe a little bit more opinionated on this. I don't believe that the lower pannus is going to pull on an abdominal wall closure and pull it apart. So I don't do a paniculectomy often. Many times the lower pannus is partly removed from essentially a vertical paniculectomy as described by Howard Langstein. When you're bringing the rectus muscles together, there's a lot of bunched up tissue in the midline and then you resect it. So I don't tend to do vertical paniculectomies, but in this paper, very few paniculectomies were done, so it wasn't a meaningful difference between the groups.
Definitely. That's a great description. Thank you for analysis. So one of my first questions, and one of the things I noted most, is they didn't really solidify how they decided on patients who got anterior component separations or the TAR release. They just said it was based on surgeon preference and their ability. And I know you've talked a lot about these things, and we hear you talk about meetings, and we've read your papers on this. What is your approach? Do you change your approach based on the patient? Do you change it based on imaging in terms of doing an anterior component separation or a TAR release? Is it based on patient factors? What's your criteria for doing one versus the other?
Well, I believe both procedures work, but my personal feeling is it's all about suture pull-through. And so the better one closes the mesh to the tissues, the less the tissues will tear. I want to have the lateral aspect of my abdominal wall very compliant and the repaired site to be solid. The TAR release uses huge meshes, so it actually decreases lateral abdominal wall compliance and moves in the opposite direction, I think, of the optimal abdominal wall. So basically, I am not a proponent of the TAR release, and I only do anterior releases because I think conceptually that has the best chance of avoiding suture pull-through in the midline. In addition, if there's a complication, a narrower mesh would be easier to remove than a huge mesh from psoas to psoas. So for many different reasons, I want a narrow mesh that's well fixed as opposed to a TAR release, which uses a minimally fixed gigantic mesh. So I'm not selecting the patient for the procedure. I think that the anterior release with the well-fixed narrow mesh is the optimal closure.
And, you mentioned suture pull-through, and I think we've all heard you talk and read papers about mesh suture and your biomechanical studies on that. Really, in what circumstances do you perform mesh sutured repair, or are you doing that routinely, or are you still investigating some of those mechanical properties with mesh suture?
Well, right now, a cylindrical mesh suture is not yet manufactured or FDA approved, but we're talking to the FDA about clinical trials. So what I do is I take a sheet of FDA-approved mesh, in this case a macroporous uncoated mesh, and I cut it to be strips 20 millimeters wide. And I pass those through the abdominal muscles like a suture, and I tie it like a suture without any underlying planar meshes. So at this point, I still have not had a recurrence from a retrorectus narrow well-fixed mesh, and I've been doing this procedure for years, and I'm in the several hundred range. Or a mesh sutured closure, which is much easier on the patient, hurts a little bit less, and you can do smaller repairs without making a big deal to the patient in terms of their overall recovery. So I'm up to 200 mesh sutured closures, and my indications now are a small closure like an umbilical hernia, or a smaller repair in someone who has medical comorbidities and you're trying to make the operation small. I did a 80-year-old with psoriatic arthritis for a 5-centimeter hernia, so I just did a mesh suture technique for him, and the whole thing took about 35 minutes. Finally, any contaminated procedure like a hernia with a bowel takedown, well, then I'm just doing a mesh sutured closure for them too, so I can avoid the downside of opening large tissue planes, and in case I ever had to remove mesh, everything would be right under the incision. Oh, I didn't mention lateral hernias, so anything in the muscles like flank hernias are just getting mesh sutures now, mesh strip closures. So the perfect patient, hernia, I'm going to be doing a long closure, they're in good shape, xiphoid to symphysis pubis, they're getting a retrorectus. And all of the other patients are getting mesh sutured closures.
Thank you. Chad, what do you think about this article? I'm curious to hear your thoughts as well.
Just by nature of the fact that I'm also at Northwestern, I've got a lot of the same opinions as Dr. Dumanian because he's been my mentor with abdominal wall reconstruction. One thing that I did want to talk about, though, was, Dr. Dumanian, you've been talking about doing mesh strip closures for small hernias. So let's talk about the opposite end for a second. Let's think about the biggest hernias that we deal with. So patients who have complete loss of domain, you do your anterior component separation, and the fascia still can't be reapproximated in the midline. What is your preferred technique at that point, and how has that evolved over the years?
The way I used to do it would be with a bridging synthetic mesh. And Chuck Butler has shown very clearly that bridging biologics or synthetics have something like 5 times the long-term failure rate of a direct supported repair when you can get the fascia together. More recently, I've been doing 2 things. First, I've been using Botox to the lateral abdominal wall in anticipation of a tight closure, and I'm giving either 50 units on a side or 100 units on a side. Because it's off-label, the patients have to buy it. I send them down to interventional radiology. They mix it with 10 cc's of saline and inject it into the transversus abdominis and internal oblique under ultrasound in multiple divided doses, like about a month before the surgery. And just clinically, it's so hard to prove. But those people have had much smoother outcomes. Second, I have on occasion used either a Whitman patch, which is essentially sewing Velcro to the edges of the abdominal wall and then bringing them back a couple days later for completion closure. And there's a new device, again, I have no connection to these devices, called Abra, which is essentially rubber bands over a piece of plastic. And you partially close the abdominal wall, you have these rubber bands spanning over a piece of plastic to prevent evisceration, and then you slowly tighten them at the bedside and then bring them back for a definitive closure later. However, again, just to keep avoiding intra-abdominal mesh, I do tend to use mesh strips to close them for their definitive repair. And I just think that that's going to keep you out of trouble as opposed to a bridging mesh.
Dr. Dumanian, this is Jordan here. A quick question. Are there any situations where you will still use biologic mesh, or what is your opinion on biologic mesh in the setting of a large ventral hernia repair?
I still have not seen, in a bridging scenario, durability of biologic mesh. There's the report by Bocciccio from Maryland, at least with Alloderm, 55 of 55 patients needed to go back to the operating room when they had bridging Alloderm. The non-cross-link biologic porcine products, are they better? I think time will tell, though my suspicion is that they're going to turn into scar, and the scar will remodel and soften over time. So the point is, who's going to get these products? Well, I think people with shortened lifespans or people with some sort of loss of intra-abdominal pressure. For instance, I use it in paraplegics where they're just not generating intra-abdominal force as much. I'm using biologics maybe once or twice a year, all of them in bridging fashion, because the mesh strip repair, the mesh sutured closures have totally changed my practice, and I just don't need a biologic underlay support for what I'm doing in a contaminated situation.
Dr. Dumanian, it's Shuja again. I just wanted to ask one more thing as we kind of wrap up this discussion on this article. Just something specific that I noted and kind of comes up is these kind of binary definitions in some of these articles. So they really talk about skin necrosis as being defined as basically black, non-viable skin, but they don't really talk about the surface area or need for further treatment, or does it need to be debrided, or do patients get vaxxed, or do patients get skin grafts? What's your opinion on including some of those things in these articles, just from a systematic standpoint, or just from an article mechanics standpoint? It seemed that for me it would be a good thing to look at the surface area of necrosis. Do patients need reoperations? What do you think about that, and what have you seen in your practice in terms of reoperating for wound complications?
Great question. As we've been trying to design our FDA trial, I've reviewed all the major series of how they define things. Novitsky, in his most recent paper that compares biologics and synthetics and contaminated closures, does a really good job of defining. I think Gico, in his Prima trial, really does a great job. He does not consider a stitch abscess as a infection, but he, again, defines what is an infection and what is not. I think NISQIP actually does the best job. They're looking at two meaningful, clear outcomes, which is a return to the operating room within 30 days or a readmission. And when you have a readmission, you can define, is it a readmission for a wound problem or for something else? So many wound issues can just be dealt with in the office with small wound openings and irrigations of seromas. Are those clinically meaningful? I would say no. Everything depends on the definition. I think NISQIP actually does the best, because a return to the hospital or a return to the operating room for a wound issue Those are meaningful endpoints. And what you said is very apropos. You could have a lot of fat necrosis with no overlying black skin, and yet that wouldn't be considered a wound complication in this series that we are reviewing today. So it really does depend on the definition. And I would look at Nowitzki or Jekyll in the Prima trial of how they define a wound issue post-surgical.
Yeah, I think that's an excellent point, and I think that translates to multiple different studies in different categories, especially in plastic surgery, is what really you categorize as a meaningful complication versus, as you said, something that can be kind of dealt with in the office. And I think that just as people are talking about readmission and need for reoperation are really the two things that kind of determine what a meaningful complication is. And even as we talk about cost and resource allocation, I mean, those are really the things that are going to be driving up costs or driving up resource utilization more than managing some of these smaller complications in the outpatient setting.
Exactly. The cost to treat a seroma in our office is probably pennies or a couple dollars to use a little lidocaine, numb someone up, irrigate out their wound with a asepto and some saline. I do this. I'm very aggressive at opening skin and draining out a seroma. It doesn't actually happen that much. And the seroma is this thickened fluid, almost like what's in a ganglion cyst, and you just want to get it out so it doesn't secondarily get infected.
That's a great point. Thank you so much. With that, we'll end their discussion of this article. Again, for everyone, remember to tune into the other two articles that we're going to be discussing in this month's podcast, as well as the PRS Journal Club podcast that we broadcast every month. And also don't forget to participate in our monthly Twitter hashtag PRS Journal Club, where we'll be able to interact directly with the authors for this month's selected article. So again, thank you, Dr. Dumanian, for joining us and for your excellent discussion.
My pleasure.
Join the PRS Journal Club. Read the monthly picks and classic pairings on PRSjournal.com. Discuss with the authors on Twitter at PRS Journal and listen to the podcast.